Heart rate.
Heart rate, altered
Pressure,
pressure. Okay, what about heart rate?
increased heart
Heart
rate,
rate. What about blood pressure?
low,
Okay, and I heard altered mental status,
cool and clammy,
cool, pale, clammy. What else?
Diaphoretic, is that one?
Okay, diaphoretic. We go into the clammy.
pupils,
What about pupils?
whether they're equal and reactive, widening, like
Whoa, what does all that mean?
possible head trauma.
Okay, but I
brain
asked you
bleed.
about shock, not head trauma. What would they be in shock?
Wouldn't it be
Yeah, yeah.
very
Like an
dilated?
aneurysm?
Why would they be dilated?
Because I know this
To dilate wouldn't be
from the video somewhere.
shock. Sympathetic. What would they be? What would your pupils be? Dilated. Why? Why would your pupils be dilated if you were losing blood and in shock?
Decreasing.
Yeah, that's why your blood pressure drops.
No, it's just like
Your sympathetic
sympathetic response, and then it causes you to like be more alert and more.
So stop and think about this. If I'm losing blood, I'm losing oxygen and sugar, correct? Which means my brain's not getting oxygen and sugar.
Everything's diverting.
So I'm going to release what drug to squeeze all that blood back to the head?
Epinephrine.
I'm going to release epi. The alpha effects of epi are going to squeeze all that red warm blood back to where?
Back to the brain.
The head.
Right.
So what do the vessels in the head have to do to allow more blood flow and more oxygen and sugar into the brain?
Dilate.
They would have to dilate. So below the neck is all vasoconstricted to drive the pressure up into the brain. The vessels in the brain would then be dilated to allow more blood flow and more oxygen and sugar into the brain. So as a result of that, your pupils would actually be dilated if you were hypoxic, if you were hypoglycemic, if you were hypovolemic, or you were in hemorrhagic shock. If they were unequal, that would be a sign of a head injury. If they were constricted, that would be a sign of an opiate. But in this type of shock that you're giving me, they would be dilated because we're basically shunning all the blood from the extremities back into the brain, which means the vessels in the brain have to dilate. What type of shock are y'all giving me here and why?
Compensated.
That's not compensated. That's not decompensated. I asked you type.
Hemorrhagic.
Oh.
Blood pressure.
So here's where we got to go.
Hypovolemic.
You have to remember we have phase, type, and stage/classes. You guys are giving me what type there?
Bulimic.
Hypovolemic. What's the other name for hypovolemic if it's specific to blood loss?
Hemorrhagic.
Hemorrhagic. Why did you give me that? All I asked you for was shock.
Well, because
It's the most common? You sure?
no. Well, yeah, it is. Isn't it?
So let me ask you this. We got like 27 people in here roughly. How many of y'all ran a gunshot wound, stabbing, or car wreck with a blood pressure below 90? Okay, about 3 or 4. So you want to say that's the most common shock?
Well, I mean, that's
How
what-
many of y'all ran an old person that was weak, not feeling well, and sick? Everybody?
Yeah.
So what's the most common shock?
Septic.
Which has opposite vital signs to that.
Huh.
Shock does not mean hypovolemic or hemorrhagic. We have to readjust that thought process. Shock means I'm not perfusing the tissue. It could be because I have a pump problem, which would be cardiogenic shock. It could mean I have a vessel problem, which would be septic shock, anaphylactic shock, spinal shock. All those type of shocks, the vessels get what? They don't constrict, they get dilated. So that would be like a vessel or container thing. Or I can have a volume shock, which would have to do with blood or fluid loss. These are how we determine our different types of shock. The phase is whether the pressure is above 90 or not. The type is the problem. All right? The type is the problem. So this type of shock you gave me right here would be what then?
I mean, it's a hypovolemic shock.
Hypovolemic or hemorrhagic? If it was nausea, vomiting, diarrhea, the best answer would be
Hypovolemic.
hypovolemic. If it was a gunshot wound, the best answer would be
Hemorrhagic.
hemorrhagic. If I asked you the phase, what phase of shock did y'all give me?
That's phase. I mean,
Huh?
phase one. Compensate.
Decompensated. Because the pressure you said is low, which means below what number?
90.
90. What stage or class of shock is that person in? Or you have no idea?
How much blood have they lost?
Huh?
How much blood have they lost?
Your vital signs tell you. So here's what we have to look at. Let's put it in a test question. A 26-year-old female, frontal collision, MVC. All right, heart rate 118, respiratory rate 26, blood pressure 80/40. All right? Based on these vital signs, you should be able to tell me what phase of shock, what type of shock, what stage of shock, and how much blood they have lost. So let's start with the phase. A phase is simply whether the pressure is above 90 or not. Is the blood pressure above 90?
No.
No. So if it's below 90, it's not compensated. What's the opposite of compensated?
Decompensated.
Decompensated. Is that early or late?
That's late.
Late. Is that localized or generalized? Generalized. So if they were to ask you what phase of shock related to this question, here's what we would look at. So let's say they go, these as my choices. They go hypovolemic, hemorrhagic, generalized, or early. The phase means whether the pressure is above 90 or not. That's all it means. If the pressure is above 90, it is compensated shock. It's early in the game. If we find the cause, we can reverse it because it's localized to the extremities. Why is compensated shock localized to the extremities?
Because the blood's being drawn into the.
Yeah, it's being drawn from the fingers and toes back to the core to keep the heart and the brain alive. That's why the fingers, toes, arms, and legs go from red and warm to cool, pale, and clammy. What is going to drive that change, so to speak? The release of what drug? Epi. What part of epi is going to make me cool, pale, clammy? And why? Epi has three parts, three effects. Alpha effects. The alpha effects of epi is what vasoconstricts. All right? So if it's going to vasoconstrict the extremities, it is going to steal the red, warm oxygen and sugar from the extremities back to the core. So if the extremities no longer have red, warm oxygen and sugar, opposite of red is pale. Opposite of warm is cool. And if the cells no longer have oxygen and sugar, they go from aerobic metabolism to anaerobic. And when they go to anaerobic, the cells start producing fats, lipids, which break down to lactic and pyruvic acid. That acid breaks down to water and carbon dioxide. So how do we eliminate acid then? We breathe it off,
We sweat it off.
pee it off, and sweat it off. So as a result of that, respirations will go up when they're in compensated shock, and they will also start to excrete that acid through the skin. That's why they become clammy. The more epi that's released, the more alpha effects are going to take place, the more blood is going to be stolen from the extremities back to the core, the clammier or more diaphoretic they will become. All right? Now, how do I know on a test question if I have alpha effects of epi? Which particular vital sign?
Respiration.
Nope.
No blood pressure.
Mechanical pulse in the And
Which part of blood pressure?
It'll be on the diastolic.
The diastolic. The alpha effects of epi are going to squeeze blood back to the heart, which is preload. Preload is my diastole. So if I saw a blood pressure of 120/98, that diastole is elevated, correct? That tells me that I'm squeezing blood back to the heart. That's the alpha effects of epi. The alpha effects are the vasoconstriction side. Does that kind of make sense? So if I was to come back over here and change this to say blood pressure 128/98, I would see the alpha effects are what's driving this person's blood pressure up, that preload. The more blood that comes in, the more it can what? Go out. So what does that tell me initially in hypovolemic or hemorrhagic shock the blood pressure should do?
Go up.
It should go up. The blood pressure should go up before it ever goes down. Because our body's going to kick in that fight or flight, which is that sympathetic nervous system, which is that release of epi to try and overcome that injury, that illness, that gunshot. Does that kind of make sense?
Sure.
How much blood does it take for me to actually drop my blood pressure?
I don't know, but
Nope. About 1,500, a liter and a half, give or take a little bit. So when I look at this, if I was to change this right here, blood pressure's above 90, the alpha effects of epi are there because I have an increased diastole. Well, in order to overcome the vasoconstriction, remember Pasquale's law. Pasquale's law is the pipe law. It tells me the smaller the pipe, the greater the pressure, the more friction loss. The bigger the pipe, the lower the pressure, the less friction loss. We do this all the time on the fire ground. Your 1-inch reel line, your red booster line, requires the highest pressure to pump at 180 psi to give you 100 gallons of water. But yet a 5-inch requires the least amount of pressure, but it gives you the most volume. The bigger the hose, the more water can go through it, the less pressure required because there's no friction loss. The smaller the hose, the less stuff can go through it, but it takes more force to push it. So whenever I increase or vasoconstrict, I'm going to increase the amount of pressure required to push through there. So if you're on the end of the nozzle fighting a fire and you need more pressure, what's the engine driver do? He throttles it up. So in order to increase pressure and overcome the alpha effects, the heart rate has to what?
Increase.
Throttle up, which is what effects of epi?
Beta 1.
Beta 1. The beta 1 effects of epi will increase heart rate. Which is why if we come back over here to this, here's my alpha effects, here's my beta 1 effects of the increased heart rate. Now, the faster the engine goes, the more oxygen it needs, and the more exhaust is going to come out because of the byproducts of combustion, correct?
Right.
So how do I get rid of the byproducts of combustion in the body?
By increasing the heart rate.
I exhale.
Exhale. Sorry.
So in order to exhale, I need bigger what?
breath.
Breath.
Breaths, which require bigger alveoli and bigger bronchioles. I need bigger surface area. So I need to make my lungs bigger. So what part of epi makes the lungs bigger?
Beta 2.
Beta 2 is going to cause bronchodilation. Whenever I look at this test question, if I have a bigger surface area, I'm going to have to breathe more air in to basically fill up that surface area. Plus, I'm going to have to exhale faster to get rid of the byproducts of acid or the carbon dioxide, which is why the respirations go up. So in this phase of shock in the sympathetic nervous system, the alpha effects of epi made my diastole go up. The beta 1 effects of epi made my heart rate go up. The beta 2 effects of epi made my respirations go up. And I can see all of that right here based on my vital signs. So with this pressure right here, what phase of shock is this person in?
Compensated.
Compensated, which is early in the game. If I find the cause, I can reverse it because it's localized to the extremities. That's all that's being affected by the shock. I haven't started shutting down my kidneys, my lungs, my heart, and my brain yet. Does that kind of make sense? That's why it's early in the game and it's localized. If I fix the problem, I may be able to reverse it. Those are all interchangeable. What if I change this from phase to type? Why'd you pick hemorrhagics instead of hypovolemic? Because it's a car wreck, it's trauma. If it would have said nausea, vomiting, diarrhea, then hypovolemic would have been a better answer. But because it's trauma, which is potentially blood loss, I would go with hemorrhagic. So the phase is based on blood pressure, the type is based on the problem. Does that kind of make sense? Now, what I want you to do is I want you to figure out how much blood this person's lost. And here's why. I can give you these exact same vital signs. All right? And I can say, guesstimate how much fluid is needed to replace blood loss. 1 liter, 2 liters, 3 liters, 4 liters. How much saline, also called isotonic crystalloid, how much isotonic crystalloid is needed to replace blood loss in this patient? This is a college level question on the registry. This is worth 3 points. It's a what?
3-to-1 ratio.
So that's the first key. For every 1 liter of blood I lose, it requires 3 liters of saline to replace it. It's a 3-to-1 ratio. Now, this isn't asking us how much fluid we would give. This is saying, hypothetically, how much fluid would this person need to replace their blood volume? Blood is thick, blood has plasma, blood has platelets for clotting, blood has hemoglobin to transport oxygen and sugar. So it's a thicker liquid than saline. Saline doesn't have any of those. So it takes 3 liters of saline to equal the amount of 1 liter of blood. So if it's a 3-to-1 ratio, now I have to figure out how much blood has this person actually lost. That's where stage or classes come in. If you remember back, we have stage 1, 2, 3, and 4. They also will call this class. Class 1, 2, 3, or 4. Stage or class 1, they've lost less than 500 mils. Heart rate, blood pressure, respiratory rate is all normal. All right? It's all between 60 to 100, and blood pressure is in the 120 to 80 range. Stage 2 is 750 to 1250. A liter, give or take a little bit. That's what I remember. It's a liter, give or take a little bit. Heart rate's up. Blood pressure's up. Respiratory rate is up. Stage 3 is 1250 to 1750, or a liter and a half, give or take a little bit. Blood pressure's down. Heart rate's up. Respiratory rate's up. Greater than 2 liters, give or take a little bit, everything starts to go down. So based on this person's vital signs, approximately how much blood have they lost? A liter. And it's a 3-to-1 ratio. So it'll be 3 liters of blood to replace that. At first glance, you're like, man, they didn't give me anything. You're right. They told you why you were there and what they wanted. The first sentence will tell you why you're there. The last sentence will tell you what they want. Do they want a phase of shock? Do they want a type of shock? Do they want a class? Do they want to know how much fluid you would give? Do they want to know how much fluid it takes to replace blood? So when I actually stop and look at this question, the reason why this is worth 3 points is because in order to get to this answer, you had to know a 3-to-1. You had to recognize that it's hemorrhagic shock, and hemorrhagic shock has class or stage 1, 2, 3, and 4, where we can actually predict how much blood they've lost based on vital signs to get that 3-to-1 ratio. So you see how we had to work multiple parts of a problem to get back to 3 liters. These are the type of questions you are going to see on the registry. I could ask you, which one of the following vital signs lets you know that the sympathetic nervous system alpha effects have been employed? The diastolic, part of the blood pressure. I could ask you which part of the sympathetic nervous system has been deployed in order to increase beta 1. So I could take this one question and I could probably sit here and hammer you with about 30 different questions and never change the scenario, because it's all about wording. It is all about reading comprehension. And what are they asking? They're not going to ask you a question that there's not an answer for. All right? What we have to understand is we got to be able to work through it. I can look at this person and I can say, okay, the type is hemorrhagic because it's trauma. The phase, because their blood pressure is above 90, is early, compensated, localized, or reversible. Do I have any of those choices? And then I can look at the type. It's hemorrhagic. Then I can look at how much blood she's lost based on her vital signs, and I can get all that data from this right here. That's what's expected of you on the register. It's not that difficult if we know how to process it. All right? That's all it is. It's knowing how to process it. I see an increased heart rate. I see an increased diastole. I know I have alpha and beta effects of epi. If I have a car wreck and they're warm and dry, they haven't lost any blood. If your blood pressure is low and you're pink, warm, and dry, it's physically impossible to have lost blood. Impossible. So if I run on somebody and their blood pressure is 70 and they're pink, warm, and dry, it is not hypovolemic or hemorrhagic shock. That's impossible. It's real simple. It's either sepsis, anaphylaxis, spinal shock, DKA, or heat stroke. How simple is that? Low BP, warm, dry skin, they have urticaria, anaphylaxis. Warm, dry skin, low BP, they got a 10. All right, sepsis. Car wreck, low BP, warm, dry skin, and they have numbness and tingling in their legs.
Spinal.
Spinal. Don't make this stuff hard. All right? Work your way through it. That's all there is. What would be the best? Or here, let's do this. How much fluid should you give? 2 to 500 fluid bolus, 25 mils per hour, 20 mils per kilo, or 2 to 500 fluid challenge. How much fluid should you give this person?
20 mils.
Let me ask you this. Do they need any fluid?
No.
They don't need any fluid. What's my rules for fluid resuscitation in trauma victims?
BP below 90.
Is it?
God, they've been raper.
What type?
Hemorrhagic.
What type? How do I know whether to use a blood pressure of 90 or something else? Controlled versus uncontrolled. What does that mean? I can stop it, put a finger on it, tourniquet on it. That's controlled. Then I would use a blood pressure of 90. If it's uncontrolled internal bleeding, I can't put a finger on it or stop it. Then I want to maintain a what? A radial pulse, which is pressure of approximately 80. If I have a radial pulse, they have a pressure of approximately 80. If I have a femoral pulse but no radial, they have a pressure of approximately 70. If I have a carotid pulse but no femoral or no radial, it's 60. If it's uncontrolled hemorrhage, I want to maintain a radial pulse, which is a pressure of approximately 80. So let's stop and think about this. She's a frontal collision MVC. They don't tell me anything about injuries, but I know that I have a release of epi, correct? Because I see the alpha, beta 1, beta 2 effects. If she is injured, most likely it's what type of bleeding? Internal, which would be uncontrolled. I can't put a finger on it, tourniquet on, and stop it. If it's uncontrolled, my goal is to maintain a pressure of 80 or radial pulse. Is she above that?
Yes.
So does she need fluid?
Not currently.
So I'm just going to start an IV just in case, correct?
Yes.
Which is TKO. We're saline locked. How often are you supposed to flush a saline lock?
30 minutes.
Every 30 minutes. So if I start an IV on you, give you 10 cc's, 30 minutes later I give you 10 cc's. At the end of an hour, you've received 25 to 30 cc's, which is the TKO rate. It's 25 mils per hour. You may also see it called TKO, KVO, TO, TMO, KO. Basically, it all means to maintain open, keep vein open, to keep open, or give them 25 cc's an hour to where it doesn't close off. This person doesn't need any fluid right now. Yes?
So if they don't need fluids, that'll be the minimum they get, right?
Correct. And I don't need to give them fluid based on their presentation right here. Does that kind of make sense? What's the difference between a fluid challenge and a fluid bolus? A fluid bolus will be given in hemorrhagic or hypovolemic shock. I'm not going to follow it up with what we call a vasopressor type drug, a dopamine, a Levophed, or an epi-drip. The reason why I don't give those vasopressors, those drugs that have alpha effects and vasoconstrict, is because if they're bleeding out and I vasoconstrict them more with the drug, it's going to increase pressure and make them do what in the hole? Bleed more through the hole. So I don't want to give a pressor to a hypovolemic or hemorrhagic shock. I want to just give them fluids. That's a fluid bolus. If I was to try fluids first and it didn't work and I wanted to take the blood vessels from dilated to constricted, that's when I would use a vasopressor. I'm trying to press the vessels back to a smaller size. So that would be a fluid challenge. I'm challenging the body to respond to the fluids. If it doesn't, then I'm going to use a pressor. That's a fluid challenge. Fluid challenges are not used in hypovolemic or hemorrhagic shock. Fluid challenges are used in like sepsis, neurogenic or spinal shock, anaphylaxis, cardiogenic shock. They're used in shocks where I need to basically take the vessels, squeeze them back down, and push the blood back to the heart. If they're losing blood, there is no blood to push back to the heart. All right? So you see how on this one, we're not asking you hypothetically based on the amount of blood loss how much fluid it would take. I'm asking you how much are you actually going to give based on this patient's presentation. What if we had this? What if I changed it to 86/40? Okay, it is stage 3, but is that controlled or uncontrolled hemorrhage?
It's uncontrolled.
It's still uncontrolled. She's still in a car wreck. She's still bleeding internally. It's uncontrolled. What is my rule for uncontrolled hemorrhage? How much fluid to give? Maintain a radial pulse or a pressure of at least what?
80.
Is she above 80?
No, yes.
She is, technically. So does she need fluid? No. It would still be 25 cc's an hour because she's not below 80. Does that make sense? Now, if I made her 70, if I took her to a blood pressure of 70/40, Uncontrolled hemorrhage, I want to maintain a radial pulse, which is a pressure of approximately 80. She is below 80 now. So now my answer would be what?
20 milliliters.
Nope.
It's
200 to 500 is what I would give. And then I would reassess. So here's what I'm going to do. I'm going to give her 2 to 500, see if I take her pressure from 70 to above 80. If that 2 to 500 doesn't work, then I'll repeat that 2 to 500 until I get to a max of what? 20 mils per kilo, or she keeps her pressure above 80. Whatever comes first. If I was to change this to the max amount of fluid you can give, then it would be 20 mils per kilo. It's all about wording, guys. It's all about wording. How much should I give based on these vital signs? 2 to 500. What's the max I can give? 20 mils per kilo. If the pressure's above 80 and it's internal bleeding, TKO. If it's controlled bleeding, you put a tourniquet on it, finger on it, stopped it. Pressure's above 90, TKO. Pressure falls below 90, 2 to 500 fluid bolus until I get the pressure above 90, or I reach a max of 20 mils per kilo, whatever comes first. Yes, sir.
Is it 250 to 500 or is it 200?
It depends on the book. The registry, they'll either do 200 to 500 or 250 to 500. And here's where you have to kind of open your mind a little bit. Every textbook is a little different. Like one textbook says 750. One textbook says 1250. So the registry is going to give you numbers somewhere between 750 and 1250. That's why I say a liter, give or take a little bit. One book says 2 to 500. One book says 250 to 500. If I make it 2 to 500, that covers every book. Does that kind of make sense? That's why they have a little bit of a range in there. Dopamine. Dopamine is 2 to 20 mics per kilo per minute. But we don't ever start at 2. We start at what? We start at 5 to 10 because that's where we get the alpha effects of the drug. So guess what they do on the registry sometimes? What should you start dopamine at? 5 mics per kilo to 10. What's the dosage range? 2 to 20. So sometimes instead of saying, what should you give dopamine at, instead of putting 2 to 20 mics per kilo per minute, they'll put 5 to 10 because that's what we're supposed to start out back of the ambulance. Is that still within the 2 to 20 mics? That's what they're going to do to you. Yes?
Will 2 to 20 be on there as an answer as well?
Not typically. They'll do one or the other. Yeah. Typically, they'll do one or the other. And what I've seen is they may go one question where it says your dosage range of dopamine, and they'll have 2 to 20. And then the next one, they'll go, what's your initial setting for dopamine? And it will say like 2 to 10 mics per kilo, 10 to 20 mics per kilo, or 15 to 20 mics per kilo. Well, what's the best answer there? 2 to 10, because that's where the 5 to 10 fell at. That's what they're going to do. All right?
So
if they need fluid, you're running 2 to 500 and then titrate it if they hold their pressure to.
Correct. So if I gave this person, my target point here is 80, which is a radial pulse. So I would give them 2 to 500. Let's say I give them 500 and their pressure goes to 82. I'm going to turn that fluid bolus off and put it back at TKO. 5 minutes go by because they're a critical patient. I'm supposed to recheck them every 5 minutes. 5 minutes goes by, they're back down in the 70s. I'll give them another 500. 5 minutes goes by, they're good. Then they bottom out again. I'll give them another 500 until I reach that max of 20 mils per kilo. I'm not going to dump 20 mils a kilo into a patient all at once. Because if I dump it in all at once and I increase their pressure too much, it can bust any clot they formed loose. Plus, it's going to dilute all their clotting factors and the thickness of the blood. So my goal is to get by with the least amount of fluid possible, but get the job done. That's why we start at the 2 to 500 to a max of 20 mils per kilo. Does that kind of make sense? Instead of just dumping it in and diluting them all at once. All right? What if I come back here and I did this. Let's do this. Let's make it 102/60. And I did this right here. I did spinal, late, reversible, vasogenic. They don't tell you what phase or what type. That's the choices. And they don't tell you what they're asking for. That's okay. Work through it. If it was spinal, I would have pinworm dry skin, shallow respirations that are normal, and my heart rate would not be elevated because I didn't have a release of epi. And they'll typically put something about paralysis or numbness and tingling in. So spinal's out, correct? Late, the pressure would be below 90. Reversible, well, pressure's above 90, that could be it. Vasogenic is what? Spinal shock. Vasogenic is any type of shock that causes vasodilation. Spinal shock, anaphylaxis shock, septic shock, DKA, those all cause vasodilation. So basically, spinal is a subcategory of vasogenic or distributive shock. So those two answers are basically the same. If they don't ask you specifically, rule things out. That's part of the test taking. If they ask you specifically, then we're going to go with it. Like if I was to add up here what phase, well, I can immediately eliminate those two because they're what? They're types. Now I'm left with basically early versus late, compensated versus decompensated, localized versus generalized, reversible versus irreversible. Does that kind of make sense? Yeah. Irreversible can only be chosen right here. This is the only one that can be irreversible because everything is what? Down. So if I have low blood pressure, but the heart and the respiratory rate is still trying, that's not irreversible. It's late, it's decompensated, it's generalized, but you can't pick irreversible yet because the heart rate and everything's still trying. Yes?
On that one with spinal and vasogenic, where you said they're basically the same, would they count either one the same, or is one better than the other?
It depends on what they're asking you. So if I was to say, you have a person, let's do, trying to word it right. So let's say you have 26-year-old female, frontal collision MBC, respirations are 14 and shallow, blood pressure 70/40, skin is pink, warm, and dry with a cap refill of 1. What is most likely the cause of her condition? Vasogenic shock or spinal shock? Spinal shock, because that's causing vasodilation. If I was to say the exact same scenario, and I said, what is the cause of her increased cap refill?
Vasogenic.
It'd be vasogenic, because it's the actual vasodilation that has moved all the red warm blood into her fingers and toes that makes that cap refill extremely fast. And what we have to remember is things that make my blood vessels vasodilate, that is a distributive or vasogenic category. All right? The type is still the spinal shock. The category that's the vasodilation part is the vasogenic or distributive. Typically, though, they're not going to put them both on there together. If they put both of them on there together, it's a distractor. Like on this one, I put these two on there together just to kind of jack with you when all I was really asking you was, what's the blood pressure and is it early or late? If I was to ask you a spinal cord injury, they're not typically going to put spinal and vasogenic. Now, what they could do is they could do this to you. So, frontal collision MBC. All right. Blood pressure 70/40. Heart rate 62. Respirations 14 and shallow. Cap refill 1 second. We got late vasogenic reversible. Patient, let's go hemorrhagic shock. Alright. So frontal collision NBC, blood pressure 70/40, heart rate 62. Cap refills 1 second. It is not hemorrhagic. Yeah, I cannot. If my blood pressure is low, I should have released epi. If I release epi, then I vasoconstrict, steal the red warm blood from the extremities, which makes the cap refill delayed, which makes the diastolic go up. Beta 1 effects makes the heart rate go up. Beta 2 effects makes the respirations go up. I don't have any release of epi in this question. Therefore, it's not hemorrhagic. So now I'm left with late, reversible, or vasogenic.
What's the heart rate, 62?
Heart rate 62. It's vasogenic because I have trauma, but I didn't have a release of epi. Why would a spinal cord injury not allow the release of epi?
Because it's blocking the release.
It's paralyzed. It can't send and receive messages to the kidneys, to the adrenal gland to release the epi. I've lost what they call the sympathetic tone. The sympathetic tone is what gives me the fight or flight when there's a problem. Well, if I lose that sympathetic tone and I paralyze those muscles, anything below that paralyzed area of the spinal cord is not going to send or receive messages or tell the body what to do. So below the injury, they vasodilate because they lost their sympathetic tone, so all the red warm blood goes to the fingers and toes. That's why the cap refills fast. It's a vasogenic issue. I'm not asking you what phase they're in. I'm saying what describes their problem. Their problem is they're vasodilated. They're vasogenic. Why are they vasogenic? Because they have what type of injury? The spinal cord in this. If you have trauma with low blood pressure and a normal cap refill or faster than normal cap refill, most times it's going to be related to a spinal cord injury. Here's another key buzzword. 14 and shallow. Why do spinal cord injuries have shallow respirations?
Mess with the medulla,
The diaphragm, and what were you saying?
the medulla stops the.
That would be in a head injury. That in a head injury, the medulla would be affected, but not in a spinal cord injury because the spinal cord comes out below the medulla. Does that kind of make sense? In a head injury, absolutely. The chemoreceptors in the medulla can't measure oxygen and carbon dioxide, so it doesn't know whether to breathe fast or slow. That's where we get the Cheyne-Stokes. In a spinal cord injury, it's all related to where the spinal cord is damaged. Above C5, between C2 and C4, your phrenic nerve comes out and controls your diaphragm. So if I have a C-spine fracture above C5, the entire chest and abdomen will be paralyzed, and those people will not breathe at all. Below C5, the phrenic nerve comes out and it runs around the spinal cord directly to the diaphragm. So if I had a fracture like at T3, T4, somewhere around the nipples, everything below here would be paralyzed except the diaphragm because that phrenic nerve bypassed and went straight to the diaphragm. So guess what would happen then? The diaphragm would move, but the chest wall wouldn't. That's why they get shallow diaphragmatic breathing. That's why there's not, I'm not going to say 100% of the time, but the good majority of test questions on the registry, when they do trauma, shallow respirations, low BP, and a fast cap refill, that shallow is another buzzword for spinal cord injury. Shallow diaphragmatic breathing. It means the diaphragm's working, but the rest ain't. And that's because of the way that nerve comes out and bypasses the spinal cord. That's why they get the shallow diaphragmatic breathing. That's a buzzword. How do I fix shallow diaphragmatic breathing?
Bag them.
Okay, positive pressure. What are the 4 methods to positive pressure ventilate your patient? CPAP is not one. Mouth to mask is the most recommended, but least common. One person BVM is the most common, but least recommended. 2-person BVM. So, the order of most recommended: mouth to mask, 2-person BVM, manual trigger device such as a demand valve, an auto vent, or what they call a flow restricted oxygen ventilated power device. It means no oxygen goes through it till you hit the button. And then the least recommended but most common is 1-person BVM. So pocket mask, 2-person, manual device, followed by 1-person BVM. Innovation and King Tube are not positive pressure devices. CPAP is not a positive pressure ventilation device. Here's why. If you put CPAP on a dead person, will it make their chest rise and fall? No. If you put an auto breather on a dead person, will it make their chest rise and fall? No. Will a cannula? Will an OPA? No. Will an ET tube? You intubate somebody, and it's just a tube unless you positive press through it with pressure. Does that make sense? Those are adjuncts and supplemental oxygens. They're not positive pressure devices.
You said that was the recommended order?
Yep. But most common is 1-person BVM. Why would they recommend it that way? Because when you take the test, you are a private paramedic on a private ambulance with no fire training, no fire department, no police department, with an EMT partner, and you have no additional help unless you what?
Ask for it.
Ask for it. Why do you think every skill sheet says scene safe, BSI, mechanism of injury or nature of illness, number of patients, additional resources? So if it's just you and an EMT partner and you want to do a 2-person BVM, that's great. Who's going to drive the ambulance? Who's going to work the monitor? Who's going to help you get them in the back of the ambulance? That's the way that test is written. The test is written that way because the majority of the United States is not fire-based EMS. If you can function with an EMT partner and nobody else on scene, then you should be able to function here in the Metroplex where we're fire-based EMS and we get engines and other paramedics on scene to help us. That's why the test is written that way. Yes?
So why is the mouth to mask thing more efficient than the 1-person BVM?
Because if you stop and think about it, the best way to get a seal on somebody's face is to push down evenly on both sides of the mask and then use your E-clamp, C down, E pull back, and then you can titrate your ventilations to rise and fall of the chest. Yeah. So think of it, you have this fat head 5,000 guy with giant face and cheeks, and you got a little bitty female with small hands trying to do a 1-person BVM. Right. She pushes down on the left side, and the right side's Spartan cheeks. That's why they recommend that pocket mask, because it takes the least amount of training. You're able to use 2 hands. 1 person can do it, and you can make rise and fall of the chest. That's why they teach it in CPR. That's why it was one of the first EMT skills you were taught, and then you never did it again. I will tell you straight up, I've been at this 28 years now. I've never used a pocket mask on a patient. I've never even seen one on an engine or ambulance. Seen them with the lifeguards, but it's been in the curriculum, and that's the rationale behind it. Right or wrong, that's the rationale. Right? And it's their test, and we're going to follow their rules. Fair enough?
All right.
All right, so spinal shock, since we're talking about it. Shallow diaphragmatic breathing, make the chest rise and fall, initially on scene. How do we get their blood pressure up initially on scene in spinal shock? Huh? Lift their legs. Now I don't want to bend them at the waist, so what do I want to do? Tilt the backboard up at the feet. That still maintains C-spine, but I tilt the backboard up. Because remember, all the blood, when they lost that sympathetic tone and the vasodilated, all the blood went to the fingers and toes, so by tilting the feet, I'm moving the blood back to the core. That's initially on scene. A spinal cord injury is trauma. What's my scene time supposed to be? Less than 10 minutes. On the way to the hospital, then I will try what to get the pressure up?
Fluid challenge.
A fluid challenge. Why a challenge?
Because you're challenging the vessels
See
to
if it
constrict.
works by,
Yep, I'm challenging it to vasoconstrict to see if it works, and if not, I'm hanging dopamine
Yee.
because the vessels are too big. So what if I said what is most likely to increase their blood pressure? Elevate the feet, fluid challenge, or dopamine? Dopamine is most likely to work because it's a vasodilation issue, but I'm going to try least invasive to most. All right? So if it says initially on scene, feet up. If it says what should you try first on the way to the hospital, fluid challenge. If a fluid challenge doesn't work, then we'll hang our dopamine to vasoconstrict back because I have a distribution problem because the vessels have over vasodilated, so it's vasogenic. Vasodilation may also cause a priapism in the male patient. They will initially have pink, warm, dry skin, but their heart rate will not go up because of no release of epi. Below the injury will be pink, warm, and dry. Above the injury will be what? Cool, pale, clammy. Now, if it's in the neck and head, there's not enough tissue there to vasoconstrict. But let's say that I have like a L1, all right? You may see the upper half of the torso be cool, pale, clammy because it can tell the vessels to constrict, but below there are pink, warm, and dry because they can't send and receive messages below that injury because the spinal cord is damaged. All right? One other thing that can happen, actually two other things, is if you have a lateral impact, you get T-boned. Driver's side door comes in, pushes me over, and it pinches the left side of the spinal cord. What's going to happen is everything below that injury on the left side will vasodilate and become numb and tingly. The right side will still have the spinal cord intact, and they'll be cool, pale, clammy, and I'll have movement. So you'll have one half of the body pink, warm, and dry, the other half cool, pale, clammy. That's called Brown-Sequard, S-E-Q-U-A-R-D, Brown-Sequard syndrome, and that's usually from a lateral impact. A front to back is going to affect both sides of the spinal cord evenly. But a lateral impact, it's only going to damage one side. So you may have one side paralyzed, pink, warm, and dry, the opposite side cool, pale, clammy. Some other things you may see related to that is you can have a spinal cord injury that gets better. A dissection that cuts it will never get any better. Once you cut the spinal cord, they never regenerate. Our cardiac cells, our nervous system cells, and our reproductive cells, they don't grow back. So if the spinal cord is cut, it's not going to fix itself. But what happens is you can have a spinal contusion. In a spinal contusion, basically what happens is they get swelling around the spinal cord and they have temporary paralysis. As the swelling goes down, it relieves pressure on the spinal cord. They regain some movement and they're not completely paralyzed. Now, they may never run again. They may never play football again, but they may be able to walk with a cane. May be able to walk with a walker. So you see the difference there. So if I was to say you run on a 17-year-old male playing football, first of all, he's playing football, and we suspect a spinal cord injury. Do we take the helmet off? Do we take the shoulder pads off? Do we take them both off or only take one off? It's either all off or all on. If we don't have an airway problem, we can typically immobilize them and then just pop the face mask off. Usually there's plastic snaps or they're Phillips head screws, depending on the type of mask. Most of them now, though, you can just take scissors and pop them. The trainer should be able to do that, but it's either all on or all off. If you take the helmet off and leave the shoulder pads on, they're going to go this way. If you leave the helmet on, shoulder pads off, it's going to tilt them. All right? So they may ask you about that. So you're holding C-spine, jaw thrust is how we'd open the airway, pads all on or all off. The kid can't feel anything from his nipple line down. On the way to the hospital, you notice his skin is going from pink, warm, and dry to starting to become a little cool, pale, and clammy, and he's starting to be able to feel his toes. Why?
Because the swelling's going down.
It was a spinal contusion, and as he's immobilized and not moving, the swelling starts to release, and as the swelling starts to go down, they start regaining some sensation. So that's how they could ask you about a spinal contusion versus a spinal dissection. Dissection, they'll be paralyzed forever. All right? If it's high up above C5, they'll be sitting in a wheelchair with a vent for the rest of their lives. If it's below C5, they may be paralyzed but not have to be on a ventilator forever. All right? Is that kind of, you see how that starts to play in? Depends on where it's at. So any questions on the spinal shock? All right, on anaphylaxis, we need to know the difference between mild, moderate, and severe. First of all, what happens is we have an allergen get in the body recognizes it as a foreign substance, and because it recognizes it as a foreign substance, it is going to have immunoglobulin E create an exaggerated immune response. That exaggerated immune response is going to release histamine. Histamine is going to cause vasodilation and bronchoconstriction. Now, depending on the severity, depends on how I'm going to manage this. Why would histamine want to cause vasodilation? Flush it out. The bigger the pipes, the quicker the blood can move. So by doing vasodilation, I can move this allergen, this bee venom, this shellfish, whatever, I can move it to the liver and kidneys to pull the trash out of it sooner. That's why they vasodilate. Over vasodilation, though, creates a problem. Too much of a good thing's a bad thing. For those of y'all that drink, 6-pack of beer, probably not a bad thing. Case of beer in an hour, no longer good. Right? It's going to make you vomit and make you sick. So a little vasodilation is good. Over vasodilation is going to start to create problems. When I over vasodilate, I start to leak blood out of the vessels directly beneath the skin. As I get blood directly beneath the skin, it causes red raised rash called hives or urticaria. That's where that's coming from. It will also start to leak plasma. As the plasma starts to leak, that water will start to accumulate in the areas with the least amount of fat. So if you stop and think about it, your eyelids, your tongue, your lips, your throat, those all have less fat than other parts of your body. Well, there's no fat to absorb the water, so the water's going to show up and make those areas of the body swell before anything else. It's called angioedema, facial swelling. The good thing about angioedema is if I swell your lips and your tongue shut, you can't eat any more of that shrimp that's causing the allergic reaction. If I swell your lips, your tongue, your throat shut, you can't take any more of that antibiotic. If I swell your throat shut, you can't inhale any more of that allergen. If I swell your eyelids shut, you can't absorb any more of that allergen. And if you think about how an allergen gets in the body, we absorb it, we inhale it, we ingest it, and we inject it. Well, if I shut off your face and your head, you can't inhale or eat any more of that allergen. That's a good thing. Except you can't freaking breathe, which is a horrible thing. And that's the problem we get into with the allergic reactions. The bronchoconstriction, the reason why they bronchoconstrict is to where you can't inhale any more of that air in. The reason why they become red and inflamed at the injection site is it makes you itch to want to try and scratch and get that bee venom out to break the injection properties. So you see how the vasodilation and the bronchoconstriction is trying to break the further entry of this allergen into the body. A mild case of it is okay. A moderate case, no good. A severe case, we're screwed. So we have to take what's going on here and decide, are they having a mild reaction, a moderate reaction, or a severe reaction? A mild reaction is basically what? Rash only, urticaria. It's basically a rash, and the airway is good. It's not involved. If I have a rash only, how do I treat it? Benadryl. Some books say 12.5 to 50. Some books say 25 to 50. I've seen both appear on the register. Don't freak. They're not going to list both together. They're not going to go A, 12.5 to 50, B, 25 to 50. They're going to list one or the other. All right? If they're over the age of 60, you're supposed to cut your medication dosages in half, which is why it'd be 12.5. If they're below 60, they get 25 to 50. That's why one of those books says that range. Does that kind of make sense? Old people get half because their kidneys aren't able to metabolize the drugs as well. So, rash only, airway's good. Give them 25 to 50 of Benadryl, also called diphenhydramine. How can you give the Benadryl? Oral, IM, and IV. It's up to you, right? We're not going to give oral Benadryl in the Biotel system, but we can give it IM or IV. If it's not too bad, give it IM because it's going to last longer. If you already start an IV, go ahead and do it. It's whatever. All right? They're both acceptable. Moderate, they have airway problems, but the blood pressure is greater than 90. Why do I need a blood pressure greater than 90 when we're looking at moderate? Because what is my first drug in moderate? Epi. My first drug is Epi. How much Epi do I give in moderate? 0.3 milligrams. IM, Epi, 1,000. What that means, it is 1 milligram of Epi in 1,000 microliters of fluid, which is 1 mil. It's 1 to 1. I don't know why they had to do the 1,000 microliters 80 years ago when they found this out, but that's what the 1,000 means. 1,000 microliters is 1 milliliter. That's where that 1,000 comes from. All right? It's still 1 milligram of drug. So 0.3 of it would be 0.3 milliliters or 0.3 cc. Reason why I give it IM is because by giving it IM, it decreases the chance of tachycardic side effects. However, I got to have a blood pressure above 90 to pull it out of the muscle and pull it out of the skin and push it through the vascular system. That's why I got to have pressure above 90. Airway problems. What is an airway problem? Wheezing? Is that upper or lower? That's lower. Wheezing comes from the lungs, it's lower. Stridor, is that upper or lower?
Upper.
Stridor, high-pitched upper airway on inhalation. Wheezing, high-pitched lower airway on exhalation. Okay, that's an example. What about swollen tongue? Is that an airway issue?
Yes.
You betcha, it's going to choke you. What about swollen throat? Swollen lips? So anything with the face, the tongue, the throat, or the lungs is an airway issue. We're going to give our Epi. Now, Epi is going to cause bronchodilation and vasoconstriction through alpha and beta effects, but it's not going to keep histamine from coming back. So I need to give Epi because it's going to reverse the bronchoconstriction and vasodilation, but I got to prevent the allergen from coming back, so I followed up with what?
Benadryl.
Benadryl. Same dose. 25 to 50, 12.5 to 50 if it's there. Now, if I give Benadryl and Epi and they're still having some wheezing, how can I target treat their signs and symptoms?
Nebulizer?
I could give a nebulizer. What if they still have some facial swelling? Solu-Medrol, 125 milligrams. So after I get the epi and Benadryl on board, I'm going to start target treating their signs and symptoms by giving them the Albuterol, giving them the Solu-Medrol. But I got to emergency effects, reverse the vasoconstriction or vasodilation, bronchoconstriction, prevent it from coming back, giving the Benadryl, and then I will target treat the remaining signs and symptoms. All right, whatever they got, I'll start target treatment. If the blood pressure is below 90 and they have airway issues, I cannot absorb the epi good enough through the muscle. So because of that, I'm going to go ahead and give my epi how?
IV.
IV. How much?
0.3.
0.3 milligrams.
1 to 10.
They're the exact same dose. They are the exact same dose, 0.3 milligrams. The difference is this is 1 to 10,000 and it's slow IV push. This was 1 in 1,000 microliters. This is 1 milligram of epi in 10,000 microliters. Also called 10 NLs. So basically this is diluted 10 times as much as this. It's still the exact same amount of drug. This is 0.3 milligrams in 1/3 cc of fluid. This is 0.3 milligrams in 3 cc's of fluid. It's been diluted 10 times. It would be, think of it like this. 1 to 1 would be 1 cup of sugar into 1 cup of water. That's 1 to 1. 1 to 10 would be 1 cup of sugar divided across 10 cups of water. It's still 1 cup of sugar they started with. In this case, it's still 1 milligram of epi they started with.
I thought you can't give. I thought 1 to 1 was for like anaphylaxis, and then 1 to 10 was like cardiac arrest.
1 to 1 is IM for anaphylaxis or for moderate. Severe anaphylaxis, 1 to 10,000, can be used slow IV push, and it is also the primary drug in all cardiac arrest. The reason why I have to use 1 to 10,000 in the IV is because, think about it, if you put that much fluid in the IV, is it actually going to go into the IV catheter? So I need to have enough fluid to push it in the IV catheter, plus I want it diluted when it hits the heart instead of potent. Here it's potent, but the muscle's going to break it down to dilute it for us.
So there's still the same amount of drugs. You're just
It's the exact same amount of drug. It's just that extremely concentrated will be broke down by the muscle. It's not broken down by anything because it's going straight into the bloodstream. So we got to break it down by adding water to it before we get it.
So it's gonna get to the heart faster, IV obviously.
Yes, because it's going straight in. I started an IV here. It's coming straight up the subclavian to the vena cava, right into the heart. There's nothing to get in its way. That's why I have to dilute it to where I don't have a strong concentration hitting the heart at once, which will cause severe tachycardia, maybe VTAC or VFib. So, slow IV push over 1 to 2 minutes. I have to prevent the allergic reactions from coming back, so I'm going to follow it up with Benadryl. If the blood pressure is still low, I could give them a fluid challenge. If the blood pressure is still low after a fluid challenge, what would probably be the best drip to hang in severe anaphylaxis where I've given epi and the pressure's still low and they're not getting better? An epi drip. Stop and think about it.
I've already given it.
If I'm giving you epi and you're not getting better, and I need to get your pressure up and your anaphylaxis, why not hang an epi drip? Does that make sense? Now, if I gave you epi and Benadryl and your pressure comes up, now I can target treat your signs and symptoms. I can give you Albuterol. I can give you Solu-Medrol. But if you're still cratering, let's say you run on this guy. So we run on a guy, he's deathly allergic to seafood. He stops at Panda Express and doesn't realize that the soup he bought has some shrimp in it. So he eats some of that soup, He swells up like a puffer fish. You get there, he's turning blue, pressure's in the 60s. You start an IV on him real quick. You give him 0.3 of epi, 1 to 10,000. You give him 50 of Benadryl. You get him back in the ambulance, and he ain't any better. His pressure's now in the 50s. He needs more epi, correct? What's better way to get his pressure up than to try and give him fluid, but do an epi drip that's going to help the pressure and help the allergic reaction simultaneously? Could we give an epi drip and bradycardia? Yeah, which was 2 to 10 mics a minute. So an epi drip can be used as a vasopressor. It can also be used for the severe anaphylaxis. It's not common, but it is an option. If the pressure comes back up, okay, we'll just go with Solumedrol, albuterol, take them to the hospital. But if they're continuing to get worse, we may have to look at giving an epi drip. If that pressure gets too low, even when we push the drug IV push, the pressure starts getting too low to try and carry it back. We got to think about that. You could also just repeat your epi IV push after 5 to 10 minutes.
If they don't give you vital signs, and they're asking, is this a mild, moderate, severe, and they don't give you vital signs, what are you looking to
What
see?
color would a severe anaphylaxis be?
Blue.
Or? Hell. Hell. Here's why. If I have vasodilation in a mild or moderate, I should have urticaria, red raised skin. If they drop their blood pressure so much that they're pulling the blood away from the skin and they start becoming pale, that is a bad thing. What if I just told you that a weak carotid pulse? If they have a weak carotid pulse, what's their pressure? It's below 90. It's 60.
Moderate.
Does that make them severe?
Yes.
Yeah. So I'm guessing it was a practice question.
Yes, sir.
Do you remember what they said? They probably gave something about the color or weak carotid pulse or thready pulse or something like
I
that.
think it was the pulse, but I was looking for a pressure.
Yeah. Weak thready carotid pulse is a pressure below 80.
So they're using ready as just super.
Super weak.
Okay.
Yeah.
I know you still a lot.
Yeah.
Ready.
And if you stop and think about it, weak and thready is because I've stolen the blood from the extremities back to the core, so it's barely there. Just like the cap refill. If I don't have cap refill, I didn't have a good pulse. It's kind of the way it goes.
And they
together.
need a fluid challenge, not a fluid bolus.
Correct. Because a fluid challenge would be followed up with some sort of vasopressin med.
Okay.
In a month, when you get your red patch, I don't give a shit what you call it back in your ambulance.
Okay.
For the next 6 weeks or so, a fluid bolus is hypovolemic and hemorrhagic shock. Everything else is a fluid challenge because you could potentially follow it up with the dopamine, epi drip, or levofed drip. Does that kind of make sense? And then once you get your red patch, you call it whatever you want back in your ambulance, as long as people know what you're talking about. You know. All right. What immunoglobulin causes release of histamine? That's going to be on your registry, and it's going to be on your final more than likely. I know for a fact immunoglobulin E has been on almost every registry test since 1993, because when I took it in 93, I was like, what the hell did that mean?
You word it in a question change.
Yes.
Monoclonal B. What is it? Releases histamine.
I don't even know.
That's what happens when you have an allergic reaction.
Yeah, releases vasodilation. Okay, done.
They didn't come out and tell you they have anaphylaxis, but they gave you 2 severe signs of anaphylaxis, stridor and urticaria. Well, stridor and urticaria are the result of histamine. Histamine is release of IgE. And that's something you have to understand on the registry. Pretty much everybody in here, if I said, tell me signs of severe anaphylaxis, you could rattle them off. The registry is going to use signs and symptoms of anaphylaxis, but never typically use the word anaphylaxis. Because we don't run on patients and you walk in and a patient goes, hey, I have severe anaphylaxis, treatment. The patients give you signs or symptoms. You take those signs and symptoms, you make a diagnosis based on what they're telling you, and then you pick your treatment. Just like everybody in here, if I said, give me the signs and symptoms of sepsis, you would start rattling them off. But if I said 72-year-old female, weak, don't feel well with a temperature of 96.9, heart rate 112, and a blood sugar of 62. She's septic.
Could be.
96.9,
She's late septic.
hypothermia.
But if I told everybody in here a temp of 102, everybody would be like, oh shit, she's septic. But you don't recognize that we also have the late sepsis, which we'll cover in a minute. But you see how there's that one side of sepsis everybody's going to get. Old, weak, don't feel well, tempo 103, septic. Old, weak, cool, they're the normal. Tachycardic, sugar lower than normal. Not feeling well, she's late septic. Those are the type of questions that get us, is because we're not putting that puzzle together. You know the signs and symptoms, but we got to put them together in a test question. If I was to walk in the door and just said, hey, write down 4 signs and symptoms of anaphylaxis, y'all would get it. It's when we put it in this format, and I don't use the word anaphylaxis, that your mind just locks up on you for no reason. Signs and symptoms is the key. Temperature is a key. Pink, warm, and dry, they haven't lost anything. Cool, pale, clammy, they're hypo something. They're hypoglycemic, they're hypovolemic, they're hypothermic, they're hypoxic. Cool, pale, clammy, they've lost something. Pink, warm, and dry, they haven't lost any blood. They haven't lost any oxygen. They don't have low sugar. They may have high sugar. That skin temp is going to help you determine what's wrong with them relatively quick. We're out here on 635 on a July day. It's 102. You go walking up on a car wreck. They hit the center median. Their air conditioner's off. Their windows are up. You should expect them to be extremely hot and sweaty, right?
Mm-hmm.
Bacon in that car. You open that car door and they are cold to the touch. I don't need anything else right there to know that they've lost a lot of blood in their stomach. Because they should be very hot to the touch if they're sitting in a car with the windows up and the air conditioning turned off. When you walk up to somebody on a hot summer day in a car wreck and they're cold to the touch, they've shut in a shit ton of blood in a hurry. That person is bleeding inside. We need to go. I don't need anything else to know, man, mechanism of injury, cold to the touch already, we got to get going. Why is somebody cold to the touch when it's 100 degrees outside? Because they're losing red, warm oxygen and sugar, aka blood. Now, if they were hot, red, and no longer sweating, okay, they had a car wreck, now they're having a heat stroke. But that skin temp is going to put us down the right path right off the bat. We have to pay attention to it. All right? Yes, sir.
Is the IgE the main immunoglobulin they like to focus on?
That's the only one that they typically test. They'll list all the other immunoglobulins. Here's the way I remember it. Immunoglobulin E causes an exaggerated immune response. Exaggerated immune response, and it needs epi.
Would they put histamine in there with it, or just one?
Not typically. What they may do up here is the release of histamine is caused, and then make you pick one of the immunoglobulins.
For them, when they're shutting like that, where's the best IV site you're gonna get? If they're shutting off,
Typically the AC.
so they still will be okay.
Yeah. It's just, it's when there's no volume in it, you're gonna have to go a little shallower. Because if the volume's gone away, and there's no resistance in there, you're gonna go through the backside a little bit easier if you stay deep. So go a little shallower. But yeah, like my AC right here, even if I'm dehydrated, that AC is gonna pop up. Now the little hand veins, yeah, they're gonna start going away.
I just meant in the sense that if you're shutting off the blood to extremity.
It's gonna start here.
EJ.
But that AC is probably still gonna be relatively good. If not, we can try an EJ depending on how bad they are. If you tell them to turn their head and they can talk to you, probably don't need an
I
EJ.
had a lady ask me to do an EJ.
Just saying. All right. Any questions over that so far?
This is gonna hurt.
Let's
a little
take
bit.
10 minutes, come back in at 9:10, and we'll keep plugging along.
So should we even learn the other ones? Like,